Thank you very much. Good afternoon, everybody. The organizers, thank you very much for this opportunity. It's a pleasure for Mildmay Uganda to share a bit of the work that we do. Just for introductions, Mildmay Uganda is an NGO, a local NGO in Uganda. We've existed since 1998, affiliated to Mildmay International in the UK and other programs around Africa. Currently, we are looking after 76,000 people in 16 districts in the central region of Uganda. The program started in 1998 as really in response to the growing number of orphans and vulnerable children that were not being reached. And I think Mildmay was one of the first organizations to provide free HIV care to children living with HIV. We've evolved over time, and today we are talking about NCDs. As others come in and join the response, then we sort of move on. We pride ourselves in modeling quality, sustainable systems to respond to HIV and other priority diseases. And so today I'll be sharing with you something more of a challenge, a description of where we are going, but more of a challenge to all of us to stretch the dollar even a bit more. HIV is a burden for Uganda, like many other countries, and we have been providing a holistic, family-centered approach to care. We've been doing opportunistic infections. We've been doing ART for both adults and children. We've been doing physiotherapy, occupational therapy, nutrition, all of it in one basket, really. Cervical cancer screening, adolescent sexual reproductive health, really at the center, and then providing technical support to over 400 facilities in the central region. But something new for us, as we looked at the epidemic, we have a growing aging population. The people we looked after, I remember the first time that the first PEPFAR drugs patient was in Mildmay, but we cast lots to choose the first 25 children who would get onto the first PEPFAR drugs, and we're all teary. But now these are grown people. They're now growing old on us, actually. And NCDs has become a reality, and the burden is growing. We looked at our data. We looked at our data from 2004 when we had PEPFAR come in. That's when we started really having our data in one place and getting it organized. Our data from 2004 to 2008. And we saw signs that we had a growing epidemic of NCDs. But specifically 2002, 2003, we looked at a cohort, and we had 1,551 patients in there who'd had a diagnosis of hypertension. The risk was higher among males and increased with age. We could look at the data because the data before, was not necessarily always consistent, because it was never collected for that purpose. It was focused on HIV. Sometimes you would have a hypertension taken, a blood pressure measurement taken in other places for outreaches and things. You may not have this data. So 2002, 2013, the cohort had 1,551 patients, and we thought this is significant. We had 10,000 patients in care then. That's really 10% of the patients having a high blood pressure diagnosis at least once, and we were like, this is significant. So we thought we needed efforts to address multimorbidity in HIV beyond TB, beyond malaria, beyond diarrhea, or beyond the usual opportunistic infections that we had been doing. Mildmay, so at Mildmay we started down the road of active case finding for all new clients, and then providing medical and behavioral interventions to reduce risk and control disease, or NCDs, among our patients. What did we do? We looked at all our physical and electronic data. We pulled it out. We wanted to know where these patients were. Are they surviving? Are they still with us? Have they left? And then we revised the data collection tools or developed tools for different spots within our care's client flow system to make sure we're capturing anybody who had risk factors for hypertension or for mental disease. We've had our staff trained. We have a psychiatrist who comes over every week, but we also have physicians that sit with the teams. We've taken our doctors through training, but we've trained community volunteers and the nurses and everybody to look out for these risk factors. We've developed SOPs and put them at different points within our system. And we continuously have a team looking at the data, cleaning, and we're feeding back to the caregivers about what's happening with each of these. We're focused on mental health, we're focused on high blood pressure, we're focused on diabetes to start with, but also cancer because of the risk among our patients. Our medical records or files are tagged, and clinicians have been sensitized on how to treat HIV and NCD comorbidities and to maximize clinic capacity to deliver on interventions, especially behavioral support interventions. We have isolated Tuesday as an elderly clinic day, but also our NCD clinic day. And we just want to make sure that we are giving our clients all the support that they need. At the end of March 2014, we had 10,285 clients active in care at Mildmay. We now have 12,456. 34% of these were aged over 60, 69% were female, 73% were on ART. 1,558 were identified with hypertension. This is just to give you the data and make you think also about your programs. 12.7% of those who had hypertension also had mental disorders, including depression and mania and epilepsy, while 8% of those, again, had diabetes. And for us, that was staggering. We haven't, this is data we are still looking at. My task was just to alert you that this is a growing problem. This is something that we have to look at. We're looking at it. There are things that we hope to share in incoming conferences, but we've learned that HIV care and treatment infrastructure provides a viable platform for screening and managing non-communicable diseases. We're learning a lot. Because this is steady data, I couldn't sort of carry it with me before the time. But diagnosis, tracking, and management of NCDs, particularly hypertension, diabetes, cardiovascular disease, mental health, as part of routine care, we have seen improves outcomes markedly. These 1,058 patients, we haven't lost any because we're looking after them. We're looking after them on all fronts and not just their HIV, because HIV then ceases to be their primary problem after so many years in care. They've grown old with it. They've learned so many things about the disease. These are the sort of patients you would push to a drug refill program for those of us who are comfortable with the terminology, because we're trying to deal with numbers. We're freeing up our doctor points to look after the very sick. But on the other hand, these clients are developing new diseases and they need our support. Obviously, the challenge for us is the way the system is set up. Most of our funding is through CDC, PEPFAR through CDC. 90% of the funding we have for the program. And the program didn't plan for all these new diagnoses of hypertension and mental disease and diabetes. And asking the patients to procure their own medications is a challenge. Adherence is a challenge. We have to keep looking for different sources for the drugs. Hopefully someone somewhere will make one pill, because the pill burden is an issue for the clients. I have HIV, I have to take Septrin, I have to take my ARVs, and now you're asking me to take drugs for hypertension, diabetes. What are we doing? What are we doing? Like I said, we'll continue to look at the data. We'll continue to learn from these patients, but we are also training community volunteers. We are conscious of the fact that taking a blood pressure measurement is something that many people can do without trouble. So we are training community volunteers to support follow-up and screening, but we also know these are diseases that run in families, and we want to scale up the home care program, and we'll continue lobbying for increased access to drugs through national and other mechanisms to support our patients. Thank you very much.